Hi guys, so in this clip I'm just going to give you a little run through as to the process that I do when I'm treating, and particularly I'm going to use the knee as an example. So if my client comes to me, I may do some special orthopedic tests, and this is to rule out if there's any ligament issues or impingement within the joint. So hopefully once they're all negative and there's no provoking of the symptoms with those tests, then I'm going to jump on to the muscular side. So what are the main movers and shakers of the knee? So what muscles primarily innervate the knee? So I'm going to be thinking the quadriceps, because they extend the leg at the knee, the hamstrings as they flex the leg at the knee, the gastrocnemius, also known as calf muscle, because that aids knee flexion, and the sartorius and gracilis, because they flex the leg at the knee. And then I'm going to be thinking a little bit more outside the box. So if my client is presenting with lateral knee pain, I'm going to be looking at the IT band. And then I'll also check the TFL, because if the TFL is tight, that could be holding the IT band taut. Then I'm going to think a bit more outside the box, to the point where I'm practically outside of the box. But it's all very relative. So if my client is presenting with instability of the knee, I would also check if there is a weakness in the glute max, because if the glute max is weak, then that can cause the knee to be unstable. So that's kind of the step-by-step process when I'm treating. It's to check, rule out any ligament issues, and then jump straight onto the muscular counterpart.